Thank you all for, can you guys hear me well?
Yes.
Okay, great. Thank you all for joining the Zoom for our bi-weekly COVID update. Today, we are going to have a discussion about electrophysiological manifestation of COVID-19. We have a pleasure of having Dr. Aisha Arshad and Dr. Jolie, both electrophysiologists at Cardiovascular, who are going to talk to us about what the manifestations of the COVID-19
So I'll see you on Tuesday.
are in terms of arrhythmias. And then Dr. Arshad will touch base on how procedures in EP lab are being managed now that we're starting to do procedures again, or have started to do procedures again. And Dr. Jolie will talk about some of the manifestation of COVID-19 as well, and some of the drug interactions that have to be considered while patients go on medication to treat COVID-19, which of course can have some potentially lethal interactions in terms of electrophysiology and arrhythmias. So having said that, welcome to both of you, and Dr. Arshad, if you want to start your presentation. Thank you.
Thank you very much. I just wanted to start off by thanking Sean, Hamid, and Liz for setting up this educational series during the COVID pandemic. I think, at least for me, attending these Zoom meetings has been educational and has helped me and my patients both. So the focus, may I ask everyone to go on mute because we're getting a lot of interference. Thank you. My task today is to talk about the EP perspective on the COVID-19 pandemic. Starting from background, COVID-19, as we all know, is an unprecedented public health emergency, both in scope and scale. Currently, there are 10.5 million cases that are confirmed and 513,000 deaths. And in the US alone, there are 2.68 million cases with 129,000 deaths. Coronavirus was first identified among an outbreak in Wuhan, China, and this was reported to the WHO in the end of December of 2019. The WHO declared this pandemic to be a global health emergency in the end of January of 2020. The WHO then declared this to be a classified as a pandemic in the beginning of March 2020. This is the first designated pandemic since 2009. Specifically talking about the state of Virginia, we now have 62,787 cases and 1,700 deaths. The state of Virginia issued stay-at-home orders in the end of March. In the month of April, everything was pretty much on lockdown, and we resumed elective procedures on May the 1st. So in the context of this, several things are pretty interesting and questions that come to mind as far as COVID. One is, what are the EP impacts of this disease? What kind of arrhythmias do people with COVID suffer from? How do we treat these arrhythmias? Number one, so that's my first task. The second task is to describe how EPs and the Heart Rhythm Society is issuing guidelines as to what kind of procedures should be done during this time of increasing COVID cases, and how do we reboot EP and get back into doing more elective type of procedures. So I'll be describing these scenarios after the discussion of COVID and arrhythmias. So COVID has multiple mechanisms which are potential triggers for arrhythmias. There's a cascade of simultaneous events that occur that make the host a good substrate, make the host heart a good substrate for all of these arrhythmias. So firstly, there's a pan-inflammatory response, an increase in autonomic tone, a hypercoagulable state. In conjunction, there's anemia, often downregulation of important receptors such as the ACE2 receptors, with a heightened anxiety state in the background of high catecholamines. This may lead to decreased cardiac and pulmonary function, hypoxemia, and may be exacerbated by pre-existing cardiac diseases. Some of the drugs that we use to treat this condition may potentially cause a lot of toxicity, particularly cardiac toxicity and sudden death. In people who are particularly deconditioned, either from a cardiopulmonary perspective or a peripheral perspective, these people are very vulnerable to these arrhythmias. And specifically, if there's myocardial injury, this may manifest as both fast heart rhythms, tachyarrhythmias, slow heart rhythms, bradyarrhythmias. The QT interval may change. And there have been reports of sudden cardiac death in the context of acute COVID infection. So although COVID-19 clinical manifestations have been described mainly as respiratory, with a growing number of infected patients, major cardiac complications are now described. In Wuhan, China, Dr. Wang and his colleagues studied 138 patients, and this report was published in JAMA in the beginning of February. In his report, he reported that 16.7% of hospitalized patients and 44% of patients in the ICUs had some type of arrhythmia. He didn't describe in detail what these arrhythmias were, but in later questions and his interviews, it became clear that it was AFib, conduction block, VT, as well as VF. And I'll go into some detail about that in a second. Interestingly, the report of the National Health Commission of China estimates that during this outbreak, some patients reported primarily cardiovascular symptoms and not respiratory symptoms. These symptoms were described as palpitations, chest tightness, rather than respiratory symptoms. In addition, there have been reports of patients experiencing late myocardial dysfunction and cardiac arrest and PEA even during the recovery phase of the illness. So the respiratory phase of the illness, the patients have recovered from and then had sudden death. So this makes this, the cardiac effects of COVID-19 particularly devastating. You're recovering from this bad illness and there's sudden death during recovery. So the report that I alluded to by Dr. Wang and his colleagues studying the characteristics of 138 patients admitted with COVID-19, some of the demographics you'll find quite interesting and recognize from the news reports that have been shared over the 3 months relating to this pandemic. So firstly, the median age. So just to orient you, the N is 138, and these columns are divided into patients who were admitted into the ICU and those who were admitted to the hospital floors. So you could see immediately there's a significant p-value of less than 0.001. There's an age differential. So most of the people admitted to the ICU were older. There wasn't a big gender differential. Medical staff were more likely, because they were very early on using PPE, more likely to not be admitted to the ICU. And the comorbidities that the COVID-19 patients had in the ICU versus the floors were, the significant values were hypertension, cardiovascular disease, diabetes, cerebrovascular disease, and COPD. And these comorbidities have been touted and quoted by Dr. Fauci and the COVID Commission, and we're recognizing these to be comorbidities and risk factors for those with COVID-19. The signs and symptoms of the disease were myriad of fever, fatigue, dry cough, anorexia, myalgia, dyspnea, expectoration, GI symptoms, dizziness, headache, vomiting, and abdominal pain. From an EP perspective, what was interesting is most other viral diseases are associated with a very elevated heart rate. In people in the ICU versus the non-ICU patients, the heart rate was pretty similar, and they weren't even that tachycardic, which I found pretty interesting. If you look at cardiovascular morbidities in COVID-19 people, the prevalence of these comorbid conditions, stratifying into two groups, COVID-19 patients and the general population, we can see that the prevalence of diabetes is 10.9% in COVID patients versus 9.8% in the general population in the United States. Cardiovascular disease is pretty equivalent between the two groups, but those with COVID are far more likely to suffer from obesity and chronic lung disease. And I'll show you this later in terms of impact on mortality as well.
So what
Sorry, I'm not sure if that was a question.
I don't believe so. Why don't you continue, Aisha?
Okay. Also looking at biomarkers to stratify people for risk of death, troponin elevation came up as one of the biomarkers that is a marker for severe disease or death. So in this paper, looking at papers from 6 different investigators with relatively young patients with COVID-19, there was an associated troponin elevation anywhere from 12 to 27% of these patients. And again, that report from Wang et al. Showed us that 16.7% of people had arrhythmias. And this was, again, found by Guo and colleagues. And the risk of death was quite high, with the odds ratio of death being anywhere between, sorry, I'm going to minimize my screen a little bit. With the odds ratio of death being anywhere between 12 to 53-fold. So the influence of these comorbidities on the case fatality rate of COVID is pretty clear. If you compare COVID to other viruses, the overall case fatality rate of COVID is 2.3%. And if you contrast this with SARS and MERS, which were far more deadly diseases, it's pretty interesting that the CFR is pretty low. But if you look at people with the comorbidities that I mentioned before, the diabetics, those with hypertension, cardiovascular disease, you can see how their odds of death actually increase with having these comorbidities. Again, looking at the Wuhan data, the percentage of arrhythmias overall was 16.7%, like I mentioned. But in those people admitted to the ICU, that percentage went up to 44.4%. And those non-ICU patients, that percentage was about 6.9%. And this is statistically significant. So those with severe COVID, with all of that heightened adrenergic and cholinergic adrenergic environment, these people are more likely to have arrhythmias. So cardiovascular and arrhythmic events have been reported in people with COVID-19. Again, we're 3 months into the data collection part of understanding this disease more, so data remains limited. From 2 case series from Wang and Guo, there is a definite increase in occurrence of arrhythmias, and it's a marker of more severe disease and an adverse prognosis. So in a bid to understand this more, Heart Rhythm Society appointed a task force, and they published this survey of over 1,100 participants to try and understand what kind of arrhythmias are people seeing in their hospitals. Of the survey participants, 26% were in academic practice, 18% were in private, and 43% were in hospital-based practices. 50% of the respondents were from outside the United States, and this represented 76 countries in 6 continents. So it was a good reflection of what EPs were seeing as far as admissions with COVID-19 patients and arrhythmias that they were observing in the field. And this was the result of the survey that was published a month ago in JICE. And what the survey showed is 35% of the survey participants had seen some type of arrhythmia. And if this was a tachyarrhythmia, the most the most common form of tachyarrhythmia that was seen was atrial fibrillation. Again, across the board, arrhythmias that occur in a high adrenergic tone environment, such as fib, flutter, atrial tachycardia, and SVT all occurred. But what I found pretty intriguing was non-sustained VT and cardiac arrest. Of these survey participants, 35% of people had seen cardiac arrest, VT, VF, and PEA. And all of these reports of people recovering from COVID and suddenly being found dead is a result of this 4 to 5% occurrence of VT, VF, and PEA. Of the bradyarrhythmias, the survey participants didn't see that many arrhythmias, so it was 18% saw some form of bradyarrhythmia. And of the most prevalent observed bradyarrhythmias, sinus bradycardia occurred in 7.6% of people, and heart block occurred also in 7.6% of people. So personally, our group has been open throughout. We've been taking care of patients in the clinics and in the hospitals, and we've had several patients with COVID-19 that we've taken care of. I've seen atrial fibrillation, I've seen flutter, I've seen a recurrent SVT, which was previously well controlled, and now it's sustained and very difficult to control. Non-sustained VT is quite common in these people. I've seen one patient with COVID-19 and sinus bradycardia requiring a pacemaker implantation. And several of my friends have seen people with complete heart block that has recovered as the patient's clinical course recovered without the need for permanent intervention. Again, we're 3 months into this pandemic, so that data will be published and more details will be available as far as COVID-19 and arrhythmic case reports that people will publish. But these are initial signals that show that both tachyarrhythmias and bradyarrhythmias are common. Tachyarrhythmias appear to be more common in a 2-to-1 ratio. I have a couple more slides as to the Heart Rhythm Society Task Force and their guidance as far as what should be done as far as EP procedures during this pandemic. This publication from Circulation came about in the end of March, just when COVID numbers were exploding across the United States. And I found this to be very helpful in terms of providing guidance as to how do we triage and prioritize procedures, what type of PPE should we be using for doing EP procedures, and what to do when we actually have patients who suffer from COVID-19. So basically this task force said at the onset of this pandemic to postpone all elective procedures. They said perform procedures that are substantially, that put our patients substantially at risk of clinical decompensation or a risk of death. And most of these procedures related to unstable arrhythmias such as VT storm, AFib flutter, or any SVT of hemodynamic significance that the patient really would be at risk of death or clinical decompensation if it was not addressed. As far as device procedures, of course, if there's a malfunctioning lead in a dependent patient that had to be addressed immediately, generator changes in dependent patients or ICDs with minimal battery remaining were also considered to be urgent procedures. People who'd had a cardiac arrest, people who had heart block or extreme bradycardia, lead extractions for people with bacteremia that was not survivable and could not be medically treated. All of these were part of this urgent procedure category, as well as TEEs and cardioversions for people with these medically refractory severe arrhythmias. Everything else that we do in EP, which is really 90% of the list, including AFib, SVT, PVC ablation, and primary prevention devices, were categorized as non-urgent procedures. And at least in the state of Virginia, while we were shut down in April, we really just did the urgent and non-elective procedures for that whole month. In most of the hospitals that I practice in, we were provided with full PPE, so we really didn't have a big PPE shortage. The patients, as soon as testing became available and more prevalent, were screened in terms of both fever questionnaires. They were questioned about high-risk procedures. And we did have coordination with our anesthesia and ICU teams as to essential procedures that were done. And as soon as testing became more prevalent, we did use a lot of that testing. As far as procedures in people with COVID-19, we used PAPR or N95 masks with surgical gowns and in a negative pressure environment. And this is from this task force recommendations. So as things have progressed, again, there's an increase in COVID in 35 states right now. There are only 2 states that are reporting a decrease in the incidence of COVID in the United States. So the situation is still quite dire. So how do we reboot EP procedures in this environment? And again, the Heart Rhythm Task Force was extremely helpful in coming up with a set of recommendations with recognition that there are high-risk areas, medium-risk areas, and low-risk areas, which are geographically very different. And so in the high-risk hot zones for COVID, depending your ability to do EP procedures is going to depend on the hospital and resources available to you. And this may be limiting in areas where most of the ICU and CCU and telebeds are taken up by a lot of patients suffering from COVID. Virginia is a medium risk area. So if the hospital resource and capacity is adequate, in Virginia, we're allowed to do at this point urgent and emergent procedures. And some of the semi-elective procedures that are time sensitive, such as people with AFib who are failing antiarrhythmics, quite symptomatic. I've started doing these procedures within the last couple of weeks. As far as PPE levels, again, across the board, whether you're in a high, medium, or low risk area, universal masking per CDC and local guidelines is recommended. And across the board, Heart Rhythm recommends, whether you're in a high, medium, or low risk area, to test all patients prior to these procedures. As far as staff, this is more controversial. Should only the symptomatic staff be tested? Should there be surveillance after every couple of weeks? This is not that clear, and it's not a routine right now in any of the hospitals that I practice in. As far as patient visitation, for COVID positive patients, it's recommended that we limit it to 0. But in other patients, we've started easing some restrictions for non-COVID units, particularly in people who are having bigger procedures. It's always better to have family around. Everyone is masked and screened as far as a fever questionnaire upon entry to the hospital. In medium risk areas such as Virginia, as far as outpatient clinics, we initially did a lot of telemedicine, and now resumption of in-person visits has occurred in accordance with guidelines such as social distancing, lighter scheduling. We're doing symptom screening in our offices and universal masking, and we still are limiting the number of people who are accompanying patients to the office. And again, remote monitoring we're pretty big on, so we do a lot of remote monitoring in our clinics. So my conclusions are, and then Joe's going to do part 2 of our talk, my conclusions are that arrhythmia manifestations and specific treatment strategies in people with COVID-19 are still being defined. They've not been well described. There are 2 case series from Dr. Wang and Dr. Guo that I described, with 16.7% of people having some form of arrhythmia, and 2/3 of the arrhythmias, at least from the Heart Rhythm survey, appear to be tachyarrhythmias. As EP reboots, there are regional considerations such as disease burden and triage of urgency and availability of PPE, availability of testing, and patient-specific risk factors in terms of we don't want people to deteriorate with their comorbidities and clinical diseases, or to be symptomatic if medical therapies are failing. So with that, I'll end my part, and I'm open to any questions.
Thanks, Aisha. It was an excellent presentation. One quick question. We've had a few patients that presented with syncope and ended up being COVID positive after they went through a syncope workup. How vigilant you are if somebody just presents with syncope these days? And do you treat them any differently if they're COVID positive in terms of their workup?
So that's a very interesting question. Syncope is on that list of potential symptoms that may be a presenting symptom of COVID. In some people, COVID is associated with severe dysautonomia, and that may be the etiology of the syncope. So as far as syncope, it's one of the top 5 reasons for which we're consulted in EP. And we do consider, being in a moderate risk area, if someone has never had syncope and now, they're coming in with syncope, that's definitely on the list of differentials. So I would definitely get that patient COVID tested. I haven't personally had a COVID positive syncopal patient, but I think there are multiple case reports that are coming through, including, I think there was a comedian 2 weeks ago who passed out in the middle of one of his shows, and he ended up being COVID positive without any other accessory symptoms. So I think it's on the list of things to be considered in today's environment.
Can I ask you a question?
Thanks a lot, Aisha. So I guess we'll move on to Joe to expand on what Aisha discussed. Thanks, Joe.
Did you have a question? I'm going to share my screen, but you can ask while I'm sharing here.
Sure. I want to thank Aisha for the presentation. And How would you approach a bradyarrhythmia or a heart block patient who is positive COVID? We had patients in the ICU that we had to put temporary wires, and any recommendations? At what point would you give somebody a permanent pacemaker? Would you consider doing that for a COVID patient who's been on temporary pacing wire for a couple of weeks in ICU?
So again, heart block, it's one of the rarer findings as far as bradyarrhythmia. One of the, it's a 2-to-1 ratio of bradyarrhythmia to tachyarrhythmia. But those people with persistent complete heart block, because there's no definite therapy and we don't know how long the disease is going to take to run its course, I would probably say if in a couple of days, the arrhythmia hasn't resolved, having a TVP in, and many of the therapies that are working for COVID, such as proning, et cetera, extremely difficult with a TVP in to avoid people getting on ventilators. So I would have a very low threshold to do a procedure such as a micra that can be later removed months later. We can easily retrieve a mitra if this person didn't have any antecedent conduction system disease. If it's an older patient and they already had some conduction system disease, it may become a permanent system for those people in that context. But we personally have just had one person with severe bradycardia who needed a micra, and they've still needed the micra weeks after the COVID has been treated.
Thank you.
Right, Joe, you're on.
Okay, I think I got it. Okay, so I'm going to move on to arrhythmia treatment considerations, and some of this does piggyback well, I think, onto what Aisha's already discussed. Let me see if I can get this to, there we go. So I'm going to cover some of the arrhythmias, not necessarily the exact breakdown that Aisha did, but more kind of into their significance and to answer the question of whether we need to treat them. I'm going to go into some treatment considerations. When we think about treatment of arrhythmias, are we treating arrhythmias or are we actually treating COVID and that's causing arrhythmias? And so that's kind of a distinction that's important to recognize. Go into some of the arrhythmic implications of the cardiovascular infections. We're seeing a lot of these type 1, 2 MIs, troponin elevations. And what does that mean long term? I think it's a question that as EPs, we're going to have to certainly keep in mind. And then time permitting, we'll go into some special situations, inherited arrhythmia syndromes, patients who then develop COVID and what that means in terms of your medications and how you monitor them and so forth. So as Aisha already covered, there's a very broad range of arrhythmias that we have seen reported for COVID, everything from sudden death causing arrhythmias to more benign atrial fibrillation. And from a treatment perspective, we really have to consider what is the mortality or morbidity benefit. In other words, if an arrhythmia is not going to carry any significant morbidity or mortality, is it worth the treatment risk? We cannot do harm, so to speak, with our treatments. I also want to point out that all the data that's available right now is in hospital, meaning that we're desperately trying to figure out how to keep people alive. But there's very little about the convalescent phase. In other words, once people leave the hospital or out of the monitored environment, exactly what's going on to them. But when you think about the disease process, the length of and the total burden of disease may actually not be the worst during the hospital stay, but it may be in the years to come. Time will tell. So two scenarios that we commonly see, at least I've seen certainly as a consultant at some of our smaller hospitals. I'll give you two of them. 75-year-old female with diabetes, hypertension, non-ischemic cardiomyopathy, COVID pneumonia, acute on chronic renal failure. Now they have non-sustained VT on telemetry. And so this is one of the common situations where as an EP I've been consulted. Another example, 45-year-old younger patient, but with HIV, diabetes, obesity. They've got a marked elevation in troponins. They've got bad ARDS. Their EF is still preserved. Their EKG doesn't show any acute injury, but now you've got new onset atrial fibrillation. And so again, seeing COVID patients having COVID problems, comorbidities, and now arrhythmias. And so I thought these are they help kind of put your thoughts in context in terms of the data I'm going to show you, how you might apply it to these patients. So as Aisha mentioned, there are a broad range of symptoms that have shown up for COVID, palpitations certainly being common, and the frequency of arrhythmias, as she mentioned in the ICU study out of China, a pretty high frequency of arrhythmias. We also see that there are, sorry, getting asked to do a lot of looking here. There are a number of more serious reports about COVID fatalities in arrhythmia. Certainly a significant amount of deaths from cardiac arrest and malignant arrhythmia, as well as reports of fulminant myocarditis and myocardial injury from the initial cohorts in China. I decided to pull this article. This was from the University of Pennsylvania in Philadelphia predominantly. And this is one of the more comprehensive US databases about the COVID arrhythmia experience. And here they took 700 patients who were admitted for COVID, kind of mid-range for age, predominant African American. And what they found is that 79 of these patients ended up in the ICU. There was a higher prevalence of cardiovascular disease, and 23% of them died. And then the remaining 621 non-ICU patients, much lower mortality, of course, the ICU patients being sicker. And what they did is they looked at the arrhythmia frequency based upon admission status, either in the ICU up in this stack right here, or in the non-ICU stack right here. All of the cardiac arrests occurred in the ICU patients. They had 8 cases of non-shockable cardiac arrest, i.e. PEA and asystole, and then 1 torsade event. And then you can see there's a breakdown of AF, bradyarrhythmias, and non-sustained ventricular tachycardia. And obviously, 11% of the patients are having the same amount of arrhythmia almost as the remaining 90%. What was interesting to me was when they looked at mortality in these 2 groups, the only thing that panned out after correction of multiple variables for predicting mortality in-house or in-hospital was the cardiac arrest patients, as it says right here. And of course, being in the ICU markedly increased your risk of having arrhythmia. So one can argue, well, we see non-sustained ventricular tachycardia. It doesn't necessarily mean they're going to die in hospital. Maybe the urgency of treatment isn't quite so high. If they can't hemodynamically tolerate a beta blocker, it's okay. We don't necessarily need to put that on. That's maybe what is suggested by this data, although certainly definitive treatment guidelines are not available. The data sets are still pretty limited. But their conclusion here is that the severity of the illness is an independent marker of cardiac arrest, and it's really the severity of index, a severity of illness that predicts these major complications. It's not so much the infection with COVID itself. So again, what are the implications for treatment here? Do we have to treat all the non-sustained ventricular tachycardia that comes in, or the AFib? Maybe not, especially in the context of other bigger COVID issues. I also get consulted for ICDs for these COVID patients. And again, what's the role for ICDs? In this small series, which is actually the 2nd largest series that's published in the United States, PA and asystole were the predominant rhythms. There was 1 episode of torsades. And so, I've certainly seen life vests utilized for patients who had PA arrest, believe it or not in my recommendation, but I do question whether there's any utility in a life vest for someone who had PEA in the context of severe COVID illness. And as I mentioned earlier, I have actually bigger concerns about the convalescent phase. What happens when people leave the hospitals in the months and years following after they've had myocarditis or a type 1 or a type 2 ACS presentation? Can we apply traditional guidelines for ICD therapy to the post-COVID cardiomyopathy and myocardial dysfunction population? I'm not sure we can. When you look at other sort of select disease states, whether it's sarcoid or otherwise, we have to make separate recommendations for those disease conditions. And in some ways, I wonder if it may be more analogous to other post-viral myocarditis states. There's a good amount of data out there about myocarditis and inflammatory cardiomyopathies. Ventricular rate is there. It's no different than our traditional ICD population. What we do see in some of the studies, however, is that ejection fraction is not alone a strong predictor of events. Certainly we've seen people with normal hearts, ejection fraction, who have had significant arrhythmias in the context of prior myocarditis. It also appears to be independent of whether there's active inflammation that can be detected or no inflammation that can be detected. We still see evidence of ventricular arrhythmiogenesis and sudden death. And so these things really kind of, I think, are going to point to a dilemma of how to risk stratify people for sudden death after they have these COVID cardiomyopathies or myocardial dysfunction, positive troponin issues. And I'm sure more studies will follow. As I look at the data, I really feel like sometimes, and I think we're on the track now, it's like building scaffolding. Everything's done logically and it makes sense. When we were initially panicking to set up scaffolding and set the data, we had a couple of misfires, but hopefully I think we're not at this stage anymore, but we're more at this stage. So the second phase, which I think comes up in a lot of EP circles, is the risk of drug-induced long QT syndrome concerns or long QT sudden death complications. Something to keep in mind for all of these situations is that the mechanism for acquired or drug-induced long QT often involves the hERG channel. It's known by a number of different terms based upon how it's labeled. We often call it the delayed rectifier potassium current channel. It's really the most common and significant mechanism of drug-induced long QT, and we do see that the effect on the QT interval is often synergistic when you use multiple drugs. The COVID state is notable for the use of multiple medications, particularly in the ICU population who has the most arrhythmias. Propofol, commonly used for sedation, it's good for being able to assess neurologic status and so forth in the intubated patients. Macrolides, the widespread use of azithromycin, antiretrovirals or antiviral agents certainly have been used or continue to be used. Zofran for nausea, all of our traditional antiarrhythmics, Haldol for behavioral problems, and of course, hydroxychloroquine and chloroquine, and some of these other agents that are being widely used. So all these agents are often utilized and overlapped in the context of COVID patients. Add to this, the hypercytokinemic state that has been identified, the cytokine storm, so to speak, in COVID patients, has been shown to cause hERG channel blockage, the same channel I just mentioned, and QT prolongation. And then myocarditis itself, whenever you have inflammation of the heart, another proarrhythmic state causing either bradyarrhythmias or atrial and ventricular tachyarrhythmias. So we see in these COVID patients, they can have underlying baseline predisposition for long QT. You had polypharmacy, distressed physiologic state, electrolyte disturbances, the hypoxemia and hypercarbia of ARDS, and you have a great torsade substrate. So there are some guidance that has been released for monitoring patients who are on QT prolonging therapies. This is actually published out of the Mayo Clinic, and it is one of probably two major publications that I do have on this talk. It is probably the more conservative of the two. But the consideration to keep in mind, suppose your prevalence of disease is 1 in 2,000 for a congenital long QT, meaning that they have a QT interval greater than 500 or they'll develop a greater than 60 millisecond increase in therapy. Sounds pretty low, but if you give 1 million prescriptions, that's 500 cases at risk. You have a nation of 270 million people, like the US, that number becomes pretty significant. But we do want to focus on treating the primary issue, which is COVID, and doing so with an acceptable risk. So we don't want to exclude people who need treatment, but we do want to make sure that the truly at-risk people don't suffer as a result of the therapies. Another issue that's raised is how do we really assess serial QT intervals in a safe fashion? You know, do we rely on just telemetry monitoring, which actually is considered acceptable by the current sort of guidelines? There's an increase in PPE consumption if you keep doing these 12 leads on patients. And the FDA actually approved under emergency use authorization, one of the cardio mobile apps to allow smartphones to be kept in the rooms with their proprietary equipment and to be able to do 12-lead EKG from outside of the room. This is a busy slide. I'll walk you through this. So basically, you have a patient who needs a QT prolonging agent or treatment. It's kind of hard to see here, but you get the standard EKG. Check electrolytes, determine if any QT prolonging medications can be stopped, Then you document any high-risk cardiovascular comorbid conditions. We expect that 1% will have a QT interval greater than 500, about 9% will be kind of borderline, and 90% of folks will be just fine. Their QT will not be over 460 milliseconds. So it's really the stop value on the Mayo's recommendation is a QT greater than 500 milliseconds should make you really stop and think about whether this medication is right for the patient. It's kind of the same thing, try and correct electrolytes, you know, put them on telemetry, stop any QT prolonging medications that aren't necessary, and either don't give it, or if you give it, you're gonna have to repeat your EKG and check again, checking for these flags, and so forth, and it kind of continues in that fashion. So the recommendation for EKG check frequency is baseline, and then also at 4 hours after the medication is given, similar to how we do it for dofetilide, and then repeating EKG 1 to 3 days afterwards. And then repeating the EKG if there's any change in clinical status, such as diarrhea that changes electrolytes or causes liver dysfunction. Cardiology consultant is generally recommended for QT intervals over 500, and then maintaining a higher than normal potassium. So rather than accepting a potassium of 4, using a potassium of 5. Let's see, time. We got time for a little bit more, maybe? Looks like it.
You're good. You're good to keep going, please.
Okay, so I hope I'm not going too fast, or I've been often accused of going too fast. I'm going to cover some of the inherited arrhythmia syndromes and some of the treatment considerations for these. Long QT syndrome is probably the best studied with the most data. I used a recommendation that was published in Heart Rhythm this actually comes from Europe. On the upper right here, the utilization of hydroxychloroquine. You can actually substitute any medication that you want in here. The algorithm was the same, so I just clipped out this section. So they're saying if people have known acquired or congenital long QT, if they're using already a QT prolonging medication, I would comment that remdesivir doesn't, as far as I know, have any clear indication that it prolongs QT interval, but they do include it here. Azithromycin, structural heart disease, or baseline bradycardia, which naturally prolongs your QT interval. Then go ahead and get an EKG at baseline. And then again, 500 milliseconds is your cutoff. If it's less than 500 milliseconds, you go ahead and give the medication, and then you repeat in 4 hours of the dosage. And then if you see problems like this, then you're going to want to keep a closer eye on their EKG. In the absence of any problems like this, you continue therapy. So a very similar sort of start the medication, close monitor, and then continue to serial monitor and stop for a QT interval greater than 500 or a marked increase in the QT interval. Not unlike how we manage dofetilide. CPVPT, as you know, is a familial arrhythmia syndrome associated with sudden death, typically triggered by adrenergic activity, exercise being one of them. Heart rate and fever appear to be neutral in terms of arrhythmogenesis in this condition. One of the caveats, or one of the, not caveats, but one of the points to remember with CPVPT patients is adrenergic agents should be avoided. So epi, dobutamine in the setting of a code or hypertensive patient, probably best not to use. Even milrinone should be used with caution because that can also stimulate the ryanodine receptor, which is the more common variant of gene mutation in this condition. And if they can hemodynamically tolerate it, continuing a beta blocker. Regatta Syndrome. Again, as you all know, another sudden death syndrome. That's the classic finding, high-risk finding is the presence of COV-ST type, ST segment elevation in V1 and V2. If you can mute your, if you just came on board, if you can mute your account, please. This has also been identified as a condition where fevers can cause this sort of EKG change, in part because temperature affects the channel that's responsible for Regatta syndrome. And hence, in accordance with the ventricular arrhythmia guidelines, We do recommend strict fever control and telemetry monitoring until the type 1 changes have resolved. This is also an ST elevation myocardial infarction mimicker, so all the interventionalists who are sweating, as COVID showed ST elevation as a common presentation or a presentation for COVID, this is just another thing that can cause that problem. So with Regatta syndrome management, again, like I mentioned, fevers are associated with the onset of ventricular arrhythmias. In the SAVRS registry, which is the registry of symptomatic Regatta syndrome patients, they also identify that age, certainly less than 5 and over 70 years, is also a risk marker for arrhythmia in this condition. And there also may be particular variants of SCN5 alpha that are more susceptible to fever-induced tachycardia. The exact ones I will pass because this is beyond the scope of this talk. So self-treatment, of course, if a fever presents, and self-isolation is recommended for these Regatta syndrome patients. If you're higher risk, meaning you have a spontaneous type 1 Regatta pattern or a history of syncope, or if you're young or really old, or not really old, but old, or you have a known sodium channel defect, you don't have an ICD, and you have a fever that's 38.5 or higher, and it isn't going away with Tylenol, then they recommend you come to the emergency room and get assessed. If the type 1 pattern is present, then they should be admitted and monitored. But if it's not present, then they can go home and self-isolate at home. And again, it's really a risk versus risk, a risk of ventricular arrhythmia event versus COVID exposure in the ED assessment for these recommendations. A couple slides on torsades. This is a pretty commonly recognized board question. The management, I think we all know pretty well. You stop the offending drug, you make sure electrolytes are tuned up as best you can, certainly, especially hypokalemia. Magnesium can be given, 2 grams followed by an additional 2, anywhere from 2 to 20 milligrams has been reported as being effective. One of my favorites is isoproterenol or Isoprel, the drug we use in the EP lab all the time. You want that to stop bradycardia and help tighten up that QT interval. And cardiac pacing can be utilized. Maxillatine can be utilized. It's got a little bit of data for the treatment of refractory torsades. Get this thing right quick. And just as an aside, I had to include some voltage tracing here for the benefit of our interventional colleagues who love them. Can't go to an EP talk without it. But Maxillatine has selective blockade activity of the late sodium channel, which is responsible for rate-dependent QT prolongation. And so what you see here is the time sort of when the voltage, the late sodium channel is active, and that kind of adds a little hump here to the phase 3 repolarization, phase 2 onto phase 3 repolarization curve. And then on the far right here, which I can't quite reach here with my pointer, that shows an example of gain of function mutation, late sodium channel current, which prolongs the QT interval, the action potential. And so Maxillatine causes this effect, it shortens it down. And at study doses of 150 to 200 milligrams twice a day, it does shorten the QT interval. And it also shortens the peak of the T wave to the end of the T wave interval, which is a reflection of the dispersion of repolarization, the heterogeneity or the arrhythmic fragility, if you will, or the arrhythmic vulnerability of cardiac myocytes. And so, again, limited data. The study I've referenced for you here is 12 patients with incessant torsades. All of them stopped. But something to keep in mind, if you're in a situation where torsades just won't stop because they've got bolus with, with ibutyline, which I've seen happen, unfortunately, something to keep in mind as kind of a rescue. There may be some benefit to the use of Maxillatine, as you may have heard as an aside, in certain LQT3 subtypes that have this gain of function mutation that I've shown you here. So some final thoughts as we wrap this up. Looks like I've done okay on time. So COVID-19 does present a myriad of challenges to the field to our field. The data on acute manifestations and potential acute therapies continues to evolve. As we know, every week there's more stuff coming in out. But I would say that the data is almost entirely inpatient. A lot of this, we don't know what the true denominator is and the true frequency for all the findings. And equally concerning or more concerning for me is also long-term sequelae. We just don't know yet because it hasn't been around enough. I know there are multiple trials and studies underway to assess the long-term arrhythmic effect of whether it's myocarditis or type 2 NSTEMI, or if it's a true kind of type 1 ACS. You know, is there cardiac impairment long-term after myocardial involvement? You know, and then how do we risk stratify all these convalescing hearts, you know, and what therapies are going to be utilized? I think all these will pose challenges for us in the coming year. I do. So that's all I have. I'll open the floor for questions, Sean, if you want to take the helm. You want to unmute yourself. Yeah. You're still muted, Sean.
Oh, thank you, Joe. It was a lot of material in a short amount of time, so you did a great job. Let's open it up to the audience. I mean, if anybody has a question, please go ahead and ask.
I have a question for Joe. What protection do you use in the EP lab when you're doing a long EP case for patients with positive COVID?
So I use well, so when this started, honestly, I was using a full face shield, N95, regular mask on top of that, which was recommended. I have found oftentimes doing devices in particular that the amount of fogging I have with all of that on, it actually starts to pose, I think, a risk to the patient. So I've evolved to using just my wraparound goggles with an N95 and a face, you know, another face mask, and that's worked out much better.
I think, you know, going forward, there's a lot of challenge as people, some of these medications, I mean, hydroxychloroquine, of course, didn't pan out, right? Doesn't sound like it's panned out. I'm not sure if there are still physicians who use that in patients with COVID-19 after the latest trial. But a lot of these medications coming through can potentially increase the QT interval, and there are patients who are already on medication that does that. So I can't imagine you guys are going to be busy trying to decide how to manage these patients as new medications get approved for treatment of COVID-19. So it's very pertinent, your talk, and thank you for both of you for taking time to educate us on this very interesting topic. So we'll adjourn here, and hopefully to see everybody back in 2 weeks for the next session. Thank you, Dr. Lee, and thank you, Dr. Arshad.
Thank you for having us.
Thank you.
Thank you.
Thank you.